afternoon, everyone. I'm Dr. Kugonza Lillian. I'm a pediatrician. I'm the moderator of today's session. You're welcome to today's Day of Lung Science webinar. Today's theme is Approach to Management of Asthma in Children with a focus on asthma medicines. Our presenters for today are Dr. Joan Nampijja, who is a pediatrician at Uganda Martyrs Hospital, Lubaga, and Dr. Rebecca Nantanda, who is a pediatrician and a senior research scientist at Makerere University Lung Institute. Dr. Rebecca Nantanda has over 12 years of dedicated experience and active engagement in research on respiratory diseases in children with emphasis on pneumonia and asthma. I would request, as your moderator, I would request that we keep muted if we are not speaking, keep our microphones muted. If you have any comments and questions, you can post them in the chat. Also, we shall have a question and answer session at the end of each presentation. I'm excited for this topic today since we have very many children in the community who are diagnosed to have asthma, but they're not on proper treatment. And there are also very many who are undiagnosed. Allow me to invite our first presenter, who is Dr. Joan Nampijja, with a case presentation. Thank you.
Good afternoon, colleagues. I hope I'm very clear. Am I audible? I request for a response. Hello?
Yes, we can hear you. Please proceed.
Okay. Thank you so much. My name is Joanita, like I presented, and I'll be presenting the case presentation for the day. Kindly go to the next slide, please. Slide. Okay, so I'm presenting this afternoon a case of an AM, a male 5-year-old who was coming from Entebbe with a mother as a next of kin, was referred to the Makerere Lung Institute by the attending pediatrician. The first date of attendance was the 15th of March this year, and I had reviewed them for 2 times this year, as you have seen. Next, present. So the presenting complaints were basically recurrent coughs for over 3 years now. The history of the presenting complaint: AM had been unwell since the 3 years of age. Parents noted the child had a progressive, dry, irritating cough with a few episodes of post-tussive vomiting. The cough was associated with wheezing, fast breathing, and failure to sleep, especially at night. It was more at night, according to the parents, in the morning, and whenever it was rainy or a cold day. It was also triggered by dust, perfumes, or fluffy clothes, or whenever the child went to do sports. The parents reported that there was no history of lower limb swelling, chest pain, or loss of consciousness. They also had reported no history of fevers, weight loss, loss of appetite, or the child had never been in contact with a person that had been diagnosed with a chronic cough or a PTB. So the mother also reported that the child had always had a wet running nose in the mornings and the evenings, and especially if they were chilly days. She reported during wet months, the symptoms were actually worse. The next slide. The review of other systems were basically unremarkable. However, in the past medical history, The mother reported the child had been attending several hospitals for care, and most of the times was usually responding to ordinary nebulization with salbutamol, given dexamethasone tablets and syrup ascoril. Had also had several admissions in regard to the same reason, and had been managed as a pneumonia on IV antibiotics with however, very prolonged or delayed recovery. A month prior to coming to Lung Institute, the child had been started on a salbutamol inhaler, getting 2 puffs twice a day, as the attending doctor had stopped use of the spacer with the mask, as they thought she was not getting enough of the relief from the salbutamol inhaler. Next slide. Her surgical history was unremarkable, though basically the child had seen an ENT surgeon and began on Montelukast for allergic rhinitis. Nutritional history was unremarkable. Perinatal, natal, and postnatal history was also unremarkable. Family social history, this was the 3rd child of the 3 children of the family. For both parents were staying with the parents. We noted positive history of atopy in the family. Mother is a known patient of eczema. Father is a known allergic rhinitis. The other siblings, however, are well. He attends a preschool. Mother reported that he's always missing most of the days in a term. Next slide. So an examination we noticed was a fair febrile at 36.5 at that admission, was pink, well hydrated, had no jaundice, was well nourished. That time he had a weight of 18 kilograms with no signs of dysmorphism. Significantly in the chest exam, he had this irritating cough that was continuous with minimal breaks of breathing, was tachypnic at 25 breaths per minute with equal air entry bilaterally, and had marked generalized bronchi, both anterior and posteriorly, with an SpO2 of 97 on room air. The other systems were very normal. Next slide. So at that time, we made a diagnosis of a moderate persistent asthma, not well controlled, in an acute exacerbation that was possibly mild to moderate. And in addition, a view of the running nose, we also made a diagnosis of the allergic rhinitis. Next slide. At that time, we noted that let's start the child on budesonide inhaler, 200 mics, and we're giving 1 puff twice a day. We also started the child on salbutamol inhaler while at the clinic, the 100 micrograms, we were giving 12 puffs 3 times in 20 minutes. And thereafter, we discharged them to continue the salbutamol inhaler at home 4 hourly for the next 3 days and stop, and would use whenever necessary. We gave in addition azithromycin treatment tablets. We continued the Montelukast that he was already on and was supposed to review them within a week. In major, we encourage that we educate the mother. We had a long talk, train her on how to use an inhaler, and started with the mask and a spacer, and when to use the salbutamol inhaler, what we call the emergency. So the first review in a week's time, the child was able to return, and mother noted it was the first time in the first 3 years that both parents and the child were able to sleep. Significantly, there were no symptoms, and an examination child was having a clear chest. We gave them another review in a month's time, and the child was stable. Mother reported child had attended school the whole of March without missing. Plan was to continue treatment and to see them in the clinic after 2 months. Thank you.
Thank you so much, Dr. Joan Nampijja, for the case well presented. At this time, we're welcoming any questions about the case. If anyone has any questions about the case, they can put up their hand, and then they'll be able to ask. Anyone with a question about the case? Okay, if there's no one with a question or anyone with any comment about the case, let's proceed to the next presenter, who is Dr. Rebecca Nantanda, to give us approach to management of a child with asthma. Thank you. Oh, there is a hand, Dr. Mary Kutesa. Kindly unmute and ask your question.
Yes, thank you, Dr. Joan, for the case presentation. I just wanted clarification on the ENT examination. Since the ENT surgeon had put them on Pabst Montelukast, were there any significant findings in the nostril? And also, what was the role of the azithromycin tablets given? Thank you very much.
We have another question. Oh, sorry, they put up their hand up, down. So at this point, I welcome Dr. Joan Nampijja to answer the question.
Thank you, Dr. Kutesa Mary. So the question was, why did we continue with Montelukast and the ENT also giving Montelukast? And did they have significant findings in the nostril? Okay, so the history of recurrent running nose with or without significant nasal pathology, the likes of hypertrophy of the nasal turbinates. You may not have to get nasal turbinates to just give Montelukast or anti-leukotriene inhibitor. You may just start the Montelukast or anti-leukotriene because you need to control these allergic symptoms. Already the running nose in presence of colds, in presence of rainy seasons, and at night, already features showing you that this child is already hypersensitive to the cold. So giving an anti-leukotriene is works as a medication to prevent that allergic rhinitis symptoms that have been presented by the child. Dr. Kugonza, Dr. Nsubuga noted that he failed to raise the hand. I suggest he types his question into the chat. Maria, I hope I've answered you.
Maybe the role of the azithromycin.
Can I just ask it quickly?
It's okay, Dr. Nsubuga. You can go ahead and ask.
Thanks a lot, the earlier presenter. My concern is that somewhere in your history, you said this child was out of school on and off, much as the child is being treated in the hospital on and off. In your plan of management, did you think about probably the triggers in this child? Why is it that at school is on and off? Probably, what is the environment at school? Could it be that in the management plan, maybe we missed out that point? Because with their treatment, much as can be there and is effective, what about the triggers that are at home that probably we have not tackled? Thank you.
May I respond, Dr. Kugonza?
It's okay, Dr. Nampijja. You can go ahead and respond.
So unfortunately, I wanted to dodge Dr. Maria's question of azithromycin because I'll be preempting the presentation. Dr. Maria, kindly, we shall chip in this answer as Dr. Rebecca goes in to make care for a child with asthma. Number two, Dr. Nsubuga's question was about the triggers. Yes, I tried to assess for all the triggers. And the only thing I didn't mention in my presentation that these triggers were home and school. They did not matter if it was only at school. Whatever what I was trying to bring out was they would make the child actually fail to attend school, normal life. because the mother reported even when they were home during holiday, symptoms were always there. I just didn't note it here, but that was it. The triggers the mother brought up very easily, basically cold weather, rainy season, with or without school were present.
Okay, thank you so much. Thank you so much, Dr. Joan Nampijja. Now let's proceed to the next presenter. If you have any other questions, you can put them in the chat. They will be answered at the end. At this time, let's invite our next presenter to take us in the next session. Thank you.
Thank you, Dr. Kugonza, and good afternoon, good morning, good evening to everyone, wherever you are. My name is Rebecca Nantanda. I'm a pediatrician and research scientist. I work here at Makerere University Lung Institute, and I'm making this presentation on behalf of the pediatric research group here at MLI. We're motivated to make this presentation because we receive quite a number of patients here. Others are referred by our colleagues. Some are referred by other patients. And we've been noting quite a number of issues which we thought we needed to share and learn more together so that we can improve the care of children with asthma. So this presentation really focuses a lot on practical issues that we encounter day to day, with a bit of explanation of the science behind what we do. So the objective of this session is basically for us to understand the rationale why we approach the management of children with asthma the way we do, why we give certain medications and not others, why the different age groups. And I'm thinking that if we are able to understand this, then it could help us practice asthma management a little better than we've been doing and eventually have better patient outcomes. So for this session, I'm going to focus on the pathophysiology of asthma, not the textbook material. I'll just highlight the implications for diagnostics and treatment. How does that pathophysiology eventually allow us to look at which diagnostic tests to carry out, which ones are important to help us diagnose asthma, but also the reasons why we choose certain medications, because at the end of the day, you have to understand the pathophysiology to be able to get the right medication for the patient and then monitor. And then I'll dwell a bit on the medications for asthma for the different age groups and for the different users. And then I'll discuss the common errors we make when we are managing our patients, the myths, the misconceptions. And these cut across both healthcare providers like us, as well as the patients and their caregivers. So I like getting back to the basics, and I'm going to start with a normal lung because you need to appreciate what the lung looks like in the context of asthma, what is the focus, so that when you're managing, you have an understanding of why you are doing things the way you do them. So this is the basic structure of the lung. But what I want us to focus on is the bronchial tree, because when we are talking about asthma, the problem is in the bronchi, the large, the medium size, and then the small bronchi. So whenever you're managing a patient with asthma, just think that you're looking at the airway, and that's really the bronchi that we are focusing on. And then the second thing, you need to have a bit of detailed understanding of the bronchi. I hope I can get the pointer. So in this bronchi, we have the alveoli, but you note that we have blood vessels, both the arteries and the veins, and then the capillaries. But very important in the case of asthma, if you look at this bronchi, this must be a small bronchi because it's eventually leading to the alveoli. It's surrounded by these muscles. These muscles are very important when we are talking about management of asthma, because some of the medications that we give target these muscles, as well as the inside or the lumen of the bronchus. So it's usually important to appreciate some of these basic things when you're talking about management of asthma. So what is asthma? It is defined as a heterogeneous disease, and every word that is in color is important. Heterogeneous means that it has various pathophysiological mechanisms, various presentations. even the response to medications can be different. So if you're, for example, giving inhaled corticosteroids and not getting a breakthrough, it doesn't mean that you have the wrong diagnosis. It may be because that particular patient will respond to another type of medication because of the heterogeneity of the disease. It's also characterized by chronic airway inflammation, and this is very important in terms of trying to identify which medications you want to give, but also the information you need to give to the healthcare provider, to the patients when you're giving health education. And then the issue of airway hyperresponsiveness. This is the hallmark of asthma, and it's something which we are looking at when we are managing the asthma exacerbations, but at the same time when you're explaining to the parents what is going on in the airways of their children. And lastly, it's airflow limitation. This is very important when you're managing. When we are saying airflow limitation, it means that this child is having difficulty taking in air as well as exhaling the air. And so when you're managing, you know that somewhere we're going to have a compromise in the respiratory system, and therefore you are likely to do things differently. And very important to note that it's the chronic inflammation that makes these patients at risk of hyperresponsiveness. And it's this hyperresponsiveness, the different mechanisms that are involved, that eventually lead to the airflow limitation. And so the signs and symptoms that we have here are as a result of the inflammation, the hyperresponsiveness, and then the airflow limitation. So the common signs we have is wheeze, shortness of breath, chest tightness for older children who can talk about this, the cough. But it's very important to note that these symptoms vary over time and in intensity. Basically, what it means that a child with asthma does not have to have this combination of symptoms all the time for you to make a diagnosis of asthma, but also that these symptoms vary over time. They're not present every time. And this is very important when you're managing, because we've seen so many patients who are managed as intermittent asthma in inverted commas, but when in actual sense, we know that in the airways, there is chronic inflammation that is going on. And also the variable airflow limitation. Sometimes the narrowing is so much, sometimes it's not so much. And so those facts need to be put into context when we are looking at managing children with asthma. Very important that this airflow limitation can become persistent, and then you get to a point where you have airway remodeling, and management of patients who have already got airway remodeling is a little harder, and they're also at risk of other complications later on in life. So we must be able to manage these patients properly to prevent the state where we have airway remodeling. So what is going on in the asthmatic airway? These pictures are just to demonstrate, I don't know whether you can see my cursor, but this is somebody with a normal airway. It is large. Somebody is able to breathe in and out comfortably. If you look at the thickness of the mucosa, it is normal compared to this person here, whose airway has become narrow and there is thickening of the mucosa. And then for somebody who might have an exacerbation where there is more narrowing of the airway, and if you turn to this side of the picture, you can see the muscles around the bronchi tightening and tightening. At the same time, you can appreciate the redness, that is the inflammation, as well as the mucus production that is associated with an exacerbation. So what we want is somebody with a normal airway like this one, as opposed to somebody who is in this state. So going to the pathophysiology, the basics. I mentioned earlier that it's the chronic inflammation which leads to the tendency to overreact, or what we call hyperresponsiveness to various agents. So the overreaction is in the lumen of, or in the bronchi. And when you look at the bronchi, it has various structures and cells that contribute to the pathophysiology of asthma. Within here, we have the epithelial cells, we have the glands that produce the mucus, we have the nerve cells, and we have other cells like the mast cells, the neutrophils, the eosinophils, and so many other cells that really contribute to the pathophysiology of asthma. So if any of these triggers, for example, the viral upper respiratory tract infections, the air pollutants such as tobacco smoke, smoke from cooking, burning rubbish, candles, perfumes, aerosols, seasonal changes where we have extremes of cold, or when it is windy and therefore dusty, and when it's a pollen season, And also the extremes of emotions. We know that anger and excitement can actually trigger an exacerbation. This is something which many people don't look at, but it's true. Exercise as well as extreme stress. So these triggers, they work within the bronchi to lead to the narrowing of the airways. And I'm just going to explain in the pathophysiology, the common pathway that we know. So when you're looking at the pathophysiology, we have to look at what are the key players in this process. We have the inflammatory cells and the mediators. So among the inflammatory cells, we have the mast cells, very key, the eosinophils, the T lymphocytes, particularly the T type 2. We have dendritic cells, the macrophages and neutrophils. So these cells play a role. And then we look at the mediators of the inflammation that happens in people with asthma. We have histamines, we have cytokines, we can have nitric oxide. And then we also come to the structure cells. And here we have the airway epithelial cells. We have the smooth muscle cells that I showed earlier around the bronchi. We have the endothelial cells in the veins and the blood vessels. And then we have the fibroblasts and myofibroblasts. These play a very important role when we are talking about airway remodeling, but we do not forget the airway nerves, because the trigger of these nerves, as we shall see later, can actually stimulate an exacerbation and bronchoconstriction. And we also have some medications that target these nerves. So this is a very simplistic way of looking at the pathophysiology of asthma. And I'm going to relate it to either diagnostics or the diagnostic tests, but also in treatment. So the common pathway you'll find in most of the literature is that somewhere there is a trigger. And this may be mold, it may be the mites, it may be the flowers that I talked about, it may be the dander, it may be the smoke. So what happens? There is an allergen, and if somebody inhales air containing any of these allergens which they react to, this dendritic cells is very good at picking up these allergies, and they present these allergens to the lymphocyte, particularly the Th2 lymphocyte. So what this lymphocyte does, it is stimulated to produce cytokines. And the key cytokines when we are talking about asthma is interleukin-4, interleukin-5, as well as interleukin-13. So in terms of diagnostic tests, we can do tests, what we call the skin prick test, to try and identify which allergens are responsible for what we see. But I want to clarify that that skin prick tests we have now do not cover all the possible allergens. So a negative skin prick test does not mean that the child does not have asthma. We've received patients who have been told that if the skin prick test is negative, then you cannot have asthma. It's not true. The kind of tests we have do not test for all the possible allergens for asthma. And then when we come to cytokines, you'll find out later as I talk about the management that there are some new medications which we can use against the IL-4, IL-5, and IL-13. So in the pathophysiology, we can target the cytokines to try and control the asthma symptoms. So these cytokines, what they do is stimulate the plasma cells to produce IgE. And just to go on to the next one. So this IgE, we can actually have some tests to look at the specific IgE or the serum IgE. So there are tests that we can do around there. Again, these are not specific tests because there are other allergic conditions like chronic allergic rhinitis, where the IgE may be elevated. So a negative or a high IgE does not necessarily mean that the patient has asthma. Likewise, if somebody has a low IgE, it doesn't mean that they do not have asthma, because there are other forms where the IgE is not elevated. But there are also current medications that we use, and they're targeting the IgE. So the IgE then activates the mast cells, which degranulate, and they release the mediators, for example, the histamines and the leukotrienes. And what these mediators do is that they act on the smooth muscles, causing constriction. They also cause airway edema and then mucus overproduction. These things that I showed earlier in the photograph. But very important to note that at the point of giving the medication, the reason I put this star, when we are giving the short-acting beta agonists, we're actually targeting the smooth muscle, this here, which is already constricted. So there is a role of understanding the pathophysiology and why you're giving SABA and not a LABA or anything else. So as a result of these pathophysiological mechanisms, we end up with this picture where we have constriction of the bronchus, or what we call bronchoconstriction. And of course, when we have an exacerbation, it's much narrower. And this is where we give rise to the symptoms that we see, the cough, the difficulty in breathing, and the other symptoms that I mentioned. But also because the airway is very narrow, some children may have low SpO2 and altered level of consciousness. These things are important to assess in every child. But I want to emphasize that I've seen so many patients who have been given cough syrups when they have asthma. The reason for the cough is the inflammation, is all these mechanisms that I've talked about. And therefore, a cough syrup is not going to help reduce the cough. We need to treat the root cause of the problem. So we have another pathway, which is specifically for IL-5. Now, IL-5 also, I mentioned that there are some medications against it, but it can activate the eosinophils, which we can also test either in the airway when we are looking at sputum eosinophils directly, or we have other tests, what we call fractional exhaled nitric oxide. Nitric oxide is a product of eosinophil metabolism. So there are some tests that we do to find out how much of the phenol, and it can give us a sense of whether this person has asthma or not. So when IL-5 activates the eosinophils then leads to production of leukotrienes and other pro-inflammatory cytokines like the ones I mentioned earlier, again leading to smooth muscle constriction, airway edema, and mucus overproduction, leading to the signs and symptoms that I mentioned earlier. So this is very simplistic, but it's a basic understanding, as we shall see later, helps us to know why we give certain medications under certain circumstances and not the others. But I want to mention that in some cases, we do not have the common eosinophilic inflammation, and we have another pathway where we have the predominant cells being neutrophils. So you'll find that the neutrophils are elevated in the airway, and this kind of inflammation, we call it neutrophilic inflammation. What is very important that for some of these children who have neutrophilic inflammation, then they will not respond to the common corticosteroids that we give. So sometimes it's important to ask yourself, if somebody is doing everything right, but they're not improving, do they have another type of inflammation, which I need to look at and then give treatment based on that. So now I'm going to shift very quickly to the medications for asthma. We have mainly two categories of medications. The first category, we call them relievers, meaning that they help to relieve the obstruction. And these can be the short-acting beta agonists. For example, we have salbutamol and terbutaline. And then we have short-acting anticholinergics like ipratropium bromide. Then we have a combination inhalers that contain formoterol. We use them as relievers in some circumstances, as I'll mention later. So it's the formoterol that we aim when we are looking at that combination, because much as it's a long-acting beta agonist, it has a very short onset of action. So it can help relieve the obstruction during an exacerbation. And then we have the controllers. These are also in different categories. So we have those which are just plain inhaled corticosteroids like beclomethasone, budesonide, and fluticasone. We also have formoterol containing inhalers combination. Mainly here we have budesonide and formoterol. We use it as a controller. And then other controllers also have a long-acting beta agonist, which does not have a short onset of action. And the common ones we have where we have a combination of fluticasone and salmeterol. And then we have the leukotriene receptor antagonist, and the common one we have in our setting is montelukast. And then lastly, we have new therapies, which we refer to as biologics. indicated in patients with severe asthma, and we usually follow the principle of personalized medicine or targeted therapy. In other words, we don't give them to everyone, but we must have a reason why we are going to give them to those particular individuals. And like I mentioned, they're in different classes. There is the anti-IgE, the anti-IL-5, anti-IL-5 receptors, and then anti-IL-4 and IL-3. There are different types of medications which are also available, and we can have a look at them in detail maybe some other time. So for this particular slide, I want to emphasize that when you are giving the reliever, whether it is salbutamol or ipratropium bromide, the only thing you want to do is to cause bronchodilation. In other words, you're opening up the airway. And therefore, if you look at the definition of asthma, you're trying to prevent or to reverse the airway limitation that has been as a result of asthma. And the reason why I'm saying this, we've seen so many children who have asthma. I already mentioned that there is chronic airway inflammation, there is hyperresponsiveness, but they're only given relievers, meaning they're not given the full package to prevent repeat exacerbations, to prevent remodeling. So I want to encourage us that whenever we see children with asthma, we need to assess them and treat them appropriately so that we both prevent the inflammation, at the same time we open up the airways using the bronchodilators. Very important to note here that if you use correctly salbutamol inhaler, the action or the response is instant. And we usually have maximum pulmonary function occurring around 16 to 90 minutes. And this is the reason why we encourage people to give the bronchodilator every 15 to 20 minutes for at least 3 doses. The challenge many times, people are nebulized once, or they are given the inhaler once, and then they think they have received the maximum pulmonary function only for the symptoms to recur. So please ensure that you give it at least 3 times in 1 hour. That's when you will have improvement in the pulmonary function. And we know that its action can actually persist for 4 to 6 hours. And that's the reason why many times you see us prescribing either 4 hourly or 6 hourly, although sometimes we go to 8 hourly, depending on the particular patient. Now, formoterol, there is no inhaler which has single formoterol. It comes as a combination. But when we are giving it as a reliever, we are aiming at the formoterol action, which sets off within 3 to 5 minutes. And because it's a long-acting beta agonist, its action can actually last up to 12 hours. So you don't need to give this frequently like we do for the short-acting beta agonists. But just to note that these relievers have other side effects or other effects, including tachycardia, anxiety, tremors, and sweating. Please monitor your patients as you give these medications, because at some of them you may need to stop and think about something else to do. But also sometimes parents may report these symptoms and we ignore them and we just continue the same medication. And when they see that their child is not well, they just stop without telling us, and we don't get the ultimate goal of asthma management, which is symptom control. I talked about the ipratropium bromide, that is the common anticholinergic we have. And this basically is targeting the acetylcholine, which we know that it's a parasympathetic neurotransmitter in the airways. So what happens that this acetylcholine is released from the airway neurons, but also some non-neuronal cells like the airway epithelial cells. It binds the airway muscarinic receptors. For the salbutamol, we are targeting the beta-adrenergic receptors, but when we are looking at ipratropium bromide, it's really the muscarinic receptors that we are targeting, because when they're stimulated, they trigger bronchoconstriction, mucus secretion, as well as inflammation. So when you are giving ipratropium bromide, we're actually trying to antagonize the parasympathetic effect of acetylcholine. And research has shown that it's not very good, it's not very effective if used singly. So we usually use it in combination with a short-acting beta agonist to achieve the kind of bronchodilation that we want. I want to talk about short-acting beta agonist monotherapy. And this case, I'm talking about where we give salbutamol inhale or nebulizer alone without accompanying it with an anti-inflammatory. It's a harmful practice because, like I mentioned earlier, it can lead to airway remodeling. And this is because it doesn't have an anti-inflammatory effect. In fact, there is some research that is coming up showing that salbutamol may actually be pro-inflammatory, meaning that it can actually make asthma worse. The other thing is that it can promote overuse of the SABA. You know, every time the patient uses the salbutamol and uses it well and gets relief, they tend to ignore the use of the anti-inflammatory because after all, when I use the SABA, I feel better. So they wait, they go to symptomatic management, not knowing that at the end of the day, they're actually not getting a breakthrough, they're just making the situation worse. So I want to encourage us to prevent or to stop that salbutamol monotherapy use. And as you'll see later, that even for mild asthma, when we give a short-acting beta agonist, we always give an anti-inflammatory. And salbutamol monotherapy has been associated with poor asthma outcomes, including worsening symptoms, like I've explained, severe exacerbations, and sometimes we have deaths that have been documented either from the side effects of SAPA, meaning they have been overused, but also the continuing airway obstruction. And it can contribute to airway remodeling, predisposing these children to COPD later in life. But we know that if asthma is not treated appropriately, there is suboptimal lung functioning, as well as accelerated lung function decline. So I'm going to go into the controllers. I mentioned that the controllers are mainly two categories, the inhaled corticosteroids and the leukotriene receptor antagonists. I'll not talk about the biologics today. So corticosteroids, we use them both in acute exacerbations for short periods of time, but very important that we use them for maintenance therapy to control the asthma symptoms. And so these inhaled corticosteroids are going to help us in really controlling the chronic airway inflammation, which leads to airway hyperresponsiveness and airflow limitation. So whenever you're giving an inhaled corticosteroid, just know that you're preventing the hyperresponsiveness and therefore airflow limitation, and eventually the patient will be controlled. And that's why inhaled corticosteroids are the mainstay treatment when we want to achieve symptom control. How do they act? The basic way of acting is that they alter the production of the mediators that I mentioned earlier. And these are the mediators that are associated with the inflammatory cells like the eosinophils, the macrophages, the lymphocytes, the mast cells, and dendritic cells. So once they control the production of those mediators, that means we shall have a reversal and control of those reactions that I mentioned earlier, and therefore will not have any symptoms of asthma in the child. I want to shift, I'm not going to go through each of these slides, but I just want to highlight most important things. When we are treating asthma, we categorize the children into 3. So there are those who are less than 6 years. We have a category which is 6 to 11 years, and then we have the adolescents. Again, for each of these children, the most important thing you want to start with is to assess the frequency of their symptoms for you to appreciate what medication you need to give. I'll just pick out one example here for the 12 to 18 years. So if a child has daily symptoms, they wake up at night at least once a week, and then they'll have low lung function, you would put them at step 4. And there is what we call the preferred mode of treatment and the alternative. Of course, some of the preferred and alternative, our choice depends on what is available in the country, but it's good to know what is the preferred and what is the alternative. As you come down, you'll find that instead of giving this every day for step 2 and step 1, where the symptoms are less frequent, we give it as needed, meaning that when they have an exacerbation, we give it. And that's why we have it as formoterol, because it will work against the exacerbation, while the ICS will take care of the inflammation that is associated with an exacerbation. Now, when it comes to children who are 6 to 11 years, again, you evaluate the frequency of the symptoms, but you'll note that the preferred in this case is medium dose ICS LABA with as needed SABA. So for children who are 6 to 11 years, at least in Africa, we do not have enough evidence to use formoterol IC combination as a needed treatment. Our first priority is where we have the ICS and long-acting beta agonists like salmeterol. But again, some of the times we prescribe depending on what is available or what can be affordable to the patient. But just to mention that even for the step 1 where symptoms are not very frequent, remember we need to have ICS whenever we give a short-acting beta agonist. So the bottom line is that there is no room for salbutamol monotherapy in management of children with asthma, whether you're managing as exacerbation or if you're managing them as for chronic care. Now, for children who are less than 5 years, please, you will see that we only use plain ISS. We don't have LABA. We've received children as young as 3 years who have been given budesonide and formoterol combination or budesonide and salmeterol combination. Please do not give combination inhalers to children who are less than 5 years. We don't have enough evidence, so we don't know the safety profile in those children. I'll shift very quickly to common errors. You can think through your practice to see if some of these relate to you. Many times we give antibiotics in acute asthma, even when there is no indication. We prescribe short-acting beta agonists, and then we add their short-acting beta agonists containing cough syrups. So you give the inhaler and you give a syrup containing salbutamol, and the child gets worse side effects. The cough syrup is not necessary once you've given the inhaler and they're going to use it correctly. Many times for children, we prescribe inhalers without spacers. For those children who are less than 12 years, they need a spacer. And then sometimes we go ahead to prescribe the inhalers, we prescribe the spacers, but we don't train people on how to use the spacers. And so they use them wrongly, and then they end up saying that inhalers don't work. And when they come to you, then you don't tease out what could be the root cause of the problem. And maybe you think it's not asthma, but when the problem is inhaler technique. I must say that one of the common reasons for failure to respond to medication is poor inhaler technique. Many times we fail to communicate to the patients or caregivers about the asthma diagnosis. And then we end up telling them you have allergic cough, or you have chronic cough, or you have pneumonia, bronchospasms. Even when we prescribe the asthma medications, we tell them anything else apart from the diagnosis of asthma. And so when you give them asthma medicines, they wonder why you're giving them medicine for disease that they actually do not have after seeing you. I've seen so many patients who have been told that if the child is not wheezing, you cannot have asthma. I want to mention that only 30% of patients, at least in children, even in an exacerbation, have wheezing. So the absence of wheeze does not mean that the child does not have asthma. I've seen many children who have gone through unnecessary investigations. The reason I labored to go through the pathophysiology, chest x-rays will not show you what is going on in the airways. The only thing you can get on a chest x-ray is hyperinflation of the chest. But there are other many causes of hyperinflation of the chest. There are other better diagnostics you can go for. We've received a number of children, 2, 3, 4, 5 years, because they have had the cough on and off, and they've been sent for chest CT scans with all that radiation to the children. Many of them have had repeated CBC. Every time they go to the emergency unit or they go for a cough, they come with almost a ream of CBC results. So I'm thinking that appreciating the pathophysiology of asthma will help us to really be able to come up with the right diagnostic tests to do for these children. And then we've seen some children where the doctor used nebulized steroids as relievers. So you see on the prescription of the patient explains that they have been giving salbutamol and nebulized steroids alternatively with the aim of getting bronchodilation. Steroids are anti-inflammatory, while the salbutamol is a reliever. Then we commonly tell our children or our parents that children will outgrow asthma. We know that for some children, as they grow, the frequency of the symptoms reduce, and they can actually get quiet and they don't have symptoms anymore. Now, the challenge is when you tell a parent that your child has outgrown asthma, essentially you're telling them that they are cured. And so when these symptoms come again, they're like, but the doctor told me that the child will outgrow. The other challenge we've seen is that many parents wait for that moment when the children will outgrow asthma. They continue going to the emergency room every now and then because they have been told after all the child will outgrow, and they reject the maintenance treatment which is very important in preserving lung function, and they end up with worse problems as they grow up. We've seen parents who have been told by us doctors that nebulizers are more effective than inhalers, and we've gone ahead to prescribe nebulizers for home use. I want to mention that if inhalers are used properly with a spacer, with a proper inhaler technique, they are much better than nebulizers. In fact, when you look at the guidelines, nebulizers are indicated in children with life-threatening asthma, but for mild, moderate, and even severe, you can use an inhaler with a spacer and the child will improve immediately. Injectable steroids, more effective than oral steroids. Most of the children we see they have received IV hydrocortisone. This is not true. The onset of action and the response for both oral and injectable steroids are the same. The challenge is that for injectable steroids, you might take a longer time trying to look for the vein, and yet we know the earlier you start the steroids, the earlier the exacerbation will be abated. And then we've seen many children where we give IV hydrocortisone day 1, day 2, day 3. For as long as you don't give an appropriate dose of the anti-inflammatory, you will not get out of the exacerbation. It will be on and off. So we need to make sure that we titrate that dose of the prednisolone if it's properly 1 to 2 milligram per kg. And then hydrocortisone is really only indicated for those ones who cannot take orally. Like I mentioned earlier, prescribing cough syrups for our asthma-related cough. Let's treat the root cause. We've seen patients who have been told that inhalers should not be used for a long time by us doctors because they've been told that your lungs will get damaged or that inhalers are dangerous. There are some where they have typical recurrent symptoms that I mentioned about, but us doctors, we told them that young children cannot have asthma. And of course, like I mentioned earlier, the common error of salbutamol monotherapy. So these are the references. I want to stop here. I can take some, I see time is against us. I want to take some questions and comments, but that's what I wanted to share with you. And I hope somebody somewhere has got some clarification on some of the issues, and we shall improve the way we manage children with asthma. Back to you, Chair. Thank you.
Thank you so much, Dr. Rebecca Nantanda, for the nice presentation. We've indeed learned a lot. Dr. Rebecca, there are some questions in the chat. Dr. Joan Tanalunjoji asks if biologics cure asthma and where they fall. And Dr. Rebecca, I invite you to see the questions in the chat and the other questions in the chat and respond accordingly.
Okay, thank you. I hope I'm still audible. Can you hear me? Oh,
yes, we can hear you.
Okay, let me go to the chat. Yeah. So let me go through these questions. There are quite many. I'll try to see. So the first one I've landed on, can adrenaline be used as a reliever? Oh, my screen is not behaving very nicely. I think somebody was asking whether adrenaline can be used as a reliever. The answer is yes, but remember, adrenaline is non-selective. I think let me just stop the share to make it easier. Adrenaline is non-selective, so it has more side effects than any other short-acting beta agonists. But also remember, it's more difficult to give, to titrate the dosing and so forth. So there are safer options. Adrenaline will lead to tachycardia, it can lead to arrhythmias, and we used to use it before, but we are looking at the safer options for our children. And if you look at the current guidelines, unless you're pushed to the wall, the choice of medication is the inhaled salbutamol that we use, and then the cascade can go on where we can sometimes use salbutamol with ipratropium bromide, and sometimes we use the magnesium sulfate, but you need to go through that cascade to be able to know that I need to use magnesium sulfate at this point in time. So it can, but it's dangerous. Only use it when you're pushed to the wall. So can oral steroids like prednisolone be used instead of ICS? Oral steroids, I don't know whether you're asking an acute exacerbation or for chronic care. Oral steroids are only used in acute exacerbations for a period of 3 to 5 days in a dose of 1 to 2 milligram per kg with a maximum of 40 milligrams. And if somebody is already on inhaled corticosteroids, it's an add-on. You don't stop the inhaled corticosteroid. You continue with their usual medication and just add on the prednisolone to deal with acute inflammation on top of the chronic inflammation. But we do not use them for chronic care except in children. It's mainly adults, but even some children, adolescents with severe asthma. But that is really at the discretion of the attending clinician. And for now, because we know the side effects of steroids, we would rather use biologics if we are able to get them. So it's something which somebody may prescribe but pain-free, but if the alternatives, it's really much better. Chronic use of steroids can, and the risk of blindness in children. If you give the right dose of the inhaled corticosteroid, remember that it's in micrograms, it's not in milligrams like the oral ones. The only side effects that have been documented commonly is when maybe some children get either bleeding or oral candidiasis. And the way we go about that, we try to ask the parents to rinse the mouth or use, when you use the spacer with a mask, the dose is not so much, and therefore you can avoid some of those side effects. You'll forgive me if I'm not able to answer all the questions. I'm trying to scan through. When do you consider to use Montelukast as a controller? So if you look at the stepwise, I didn't go through the details, but Montelukast is an alternative for children who are less than 5. But I must emphasize that many times when you are practicing medicine, you will need to look at the patient. Sometimes they're not able to afford the inhaled corticosteroids that we want to give them with a spacer. Sometimes they've even bought them, but they're unable to do the technique correctly. So you need to work with your patient and see, when do I give them Montelukast? So we've been able to give them to patients who are unable to afford the inhaled corticosteroids, which is our first choice, or they have them, but they're unable to give the inhaled medication for one reason or the other. But sometimes we also commonly give it to children who have cough as the only symptoms, which we mainly refer to as cough variant asthma. What is the earliest age we can make an asthma diagnosis? I know we've had one time we had a baby who was 6 months. So it's not about the age, it's about taking the correct history and the recurrence, the typical recurrence of the symptoms and what is usually done when they get the symptoms. That is most important. So we don't have a particular cutoff. What I would recommend is that you have the comprehensive history and find out if they fit the picture of asthma. And what we do, we usually give them a trial of the medication for 1 month, at most 2 months, and then you withdraw the medication and see what happens. If the symptoms recur on withdrawal of the medication, then that can confirm that you are dealing with asthma, even though we are not able to have specific diagnostic tests for that particular age group. Okay. Who gets treated as outpatient versus inpatient in asthma treatment? Usually, when the patient comes in, whether they have mild, moderate, severe, or life-threatening, when you give them the medication, please assess, because somebody may have come with, for example, severe asthma exacerbation, and then you give them the treatment and they improve and they do not have to spend a day in hospital. So the decision whether to admit or not is usually made at least after the first 3 doses, because they give you a sense of whether the patient is improving, meaning that you assess the respiratory rate, the SpO2, and the other parameters, and they are getting better. So it's not something you may need to do at first hand. You must monitor your patient properly. How long do we give Montelukast and the dosage? How long depends on the patient response. That's why you saw Dr. Joanita saying that we review them after 2 weeks, after 1 month. So every time we review them, we assess the symptoms. So they would be able to move from step 4, for example, to step 3, to step 2, to step 1, and then they get controlled. And once they get controlled, we need them to be controlled for at least 3 months before we think of stopping the medication. And we use the asthma control tools to be able to gauge where they are, because it's an objective measurement of the response to medication. Is there a role of dexamethasone tablets as opposed to prednisolone, since parents complain a beta test of prednisolone are not well tolerated, okay, pill burden and so forth? So what we have in literature, in a few cases, we've seen dexamethasone being used for asthma exacerbations, but really the drug of choice is the oral medication, or rather oral prednisolone. My challenge is usually we see patients coming in with IV dexamethasone every 2 weeks. We've seen some patients who we even send to endocrinologists because they have these Cushingoid features, which have been started by us. So again, preferably the oral prednisolone. In a few cases, we may give dexamethasone, but we know that if you give it, if you have a good understanding of how to give medicines to children, there are other ways you can actually make beta tablets be given to the children and they take it properly. Role of aminophylline, it's the last resort. It's no longer something we give first time. And if you go through the guidelines, it's something which we give if salbutamol has failed, salbutamol ipratropium has failed, magnesium sulfate has failed, and you'll find that such a patient would be in ICU where we are able probably at least to monitor the cardiac activity, because we know that aminophylline has a very narrow therapeutic index and many patients are prone to arrhythmias and they die because of the medication, not because of the asthma. For how long should we prescribe the controller medication? Again, I said it depends on the patient, and I think I explained the steps you go through to try and reduce the dose and eventually stop the medication. When does oxygen become useful in management, and how do we prevent dependence in children? I don't know that these are two questions, but when you have low oxygen saturation, you need to give the child oxygen. Remember, I said that the airway narrowing is what leads to low oxygen uptake. And therefore, you would need to save the lives of these children by giving them oxygen. And we know that for those who need nebulization, the oxygen can actually be used to run the salbutamol solution so that you're able to nebulize at the same with a salbutamol at the same time giving oxygen to these children. Quite a number of questions. And role of antihistamines in chronic care, absolutely no. I mentioned in the pathophysiology, much as histamine is released, but remember the downstream is that we are looking at the inflammation. So we want to treat the root cause of the problems, which is chronic inflammation, and therefore you want to give anti-inflammatory medication. And in this case, the choice is inhaled corticosteroids. Is it okay to give Montelukast at the same time with combined inhaler for control? So usually we start with inhaled corticosteroid. If you give it correctly in the right dose, the right technique, and your patient, many times the challenge is that we want improvement within 1 or 2 weeks, the symptoms to have disappeared. A few patients that may help, but we know that the reverse of the symptoms may take a while, and we need to explain this to the parents. So the priority is give ICS. Where you see prescriptions combining ICS with Montelukast, most of those children have the comorbidity of chronic allergic rhinitis. I see Dr. Helen, her hand up. I think she might want to explain some more. Dr. Helen, please, the floor is yours. I'll pause here for now.
Thank you very much, Rebecca. I was trying to make you catch your breath. Yeah, I just want to make a comment or a few comments. From the questions, it is clear that we need guidelines. We need to use guidelines because we can't, for example, the duration of treatment, which drugs to combine. I know you went through them, but if something is new, you may not grasp it at when it is mentioned once. So I encourage that we use guidelines. And in our setting, we can use the worldwide guidelines, which are available, especially for our resource-limited setting. And those are the GINA guidelines, or Global Initiative for Asthma, GINA. When you put GINA online, you will get something, and you're able to download a summary of what what you can use in practice. That will, it will help us to understand when to give what and for how long. Yeah, the duration of treatment. Then I want to make, just to emphasize the point of using steroids. Steroids are not a safe drug to use many times in asthmatic children. In fact, the guidelines say that if you use them more than 2 times in a year, then that patient becomes a high risk for severe exacerbation, which can become life-threatening. So I urge us really to be very slow in prescribing steroids. And unfortunately, we prescribe them for long periods, so the patient ends up getting a lot when they don't need it. What is recommended is to give a big dose for a few days, usually 3 days. But the issue of tapering what doesn't apply in asthmatics, because when they get an acute episode, it is acute. It doesn't become now treatment for chronic. It doesn't become chronic treatment. And of course, let's remember, people have asked about using oral steroids for chronic care. It does not exist, except in certain settings, which are really at a very specialized level. So at our level, let's just know that we shouldn't use oral steroids for chronic care because we end up using big doses. So we should aim at using the inhaled steroids, which give the patient small doses, which will minimize the side effects. Small doses to where it is required in the lungs, and we don't have to swallow and make it spread to the whole body and cause side effects. As you know, there are many side effects from steroids. Yeah, that's what I wanted to comment on. Over.
Thank you, Dr. Helen. I'm going to answer 2 questions and I give Dr. Roland a chance to ask the question. Before I forget, 2 questions. Does severe acute asthma mean the same as acute exacerbation of asthma? Is categorized in 4 ways. It could be mild, moderate, severe, or life-threatening. So when we say acute asthma exacerbation, we need to go ahead and categorize it because it gives guidance on how to manage that child. And then the other question was about the biologics. Do they cure asthma? That's interesting. It's a common question you'll get from your patients, even as you give them the daily medication. But getting back to the pathophysiology of asthma, for somebody to start developing asthma symptoms, it's an interaction between mainly the genes and the environment. And many times I've had to explain to my patients that if you do not know anybody in your family who has asthma, it doesn't mean that your child cannot have asthma, because the fact is that you do not know everybody you share the genes with. So it's not just about the immediate family that if you don't have asthma, you cannot have asthma. That gene may have come from generation and generations. But what we know that interaction is very important. And so when we are treating asthma, the goal is to control the symptoms. And so when patients ask me whether the children will be cured, my first question to them is, what would you consider a cure? And many times all they want to hear is that my children should be able to go to school, my child should be able should be able to sleep through the night, I don't have to worry about running to the clinic every now and then. And then you explain to them. But for the case of the cure, because we cannot do for now any gene therapy, the risk of the symptoms can remain. And this needs to be communicated so that when the symptoms occur later in life, they can know that we need to address this as asthma and they go for the correct treatment. Roland, please ask your question quickly. I will need to be advised when to stop because I could talk until tomorrow.
Dr. Nantanda, also there is a comment in the chat, a request in the chat. Someone requests that you illustrate a proper inhaler use.
Online, I don't have my gadgets here, but there are many YouTube illustrations. You can go to YouTube, it can illustrate, but I think like Dr. Helen mentioned, probably we need to have more of these. It's difficult to illustrate without a patient. You need that practice really to be able to appreciate it. So maybe we'll need to think through how do we get to illustrate the inhaler technique so that people can appreciate. But for the start, you can go to YouTube and look at how to use a spacer with a mouthpiece, a spacer with a mask, but also for the adolescents and older people, how you use the inhaler without a mask. Roland, please.
Thank you very much for that amazing presentation. So just a few questions I have, perhaps to start with the spacer, with the inhaler use. I just wanted to know that if in your vast experience, you found that oftentimes many of our patients may not be able to afford over-the-counter inhalers, and we have to improvise, say with a water bottle, plastic water bottle. In your experience and your research, have you found that to be just as effective as using the commercially produced inhalers? And if so, have you perhaps in your experience found that there's a specific size of mineral water bottle or plastic bottle, and how to kind of improvise one that you would recommend for patients to use? So my other question is kind of theoretical, but just please bear with me. We know that the inhaled steroids are going to mostly have their effect within the bronchial tree. So for people who might have latent TB, does the use of steroids put them at a theoretical risk? Because we know that the formation of a granuloma is maintained by the interferon gamma and the IL-12. So when you give them the steroids, which inevitably decrease the production of all cytokines, isn't there a risk of perhaps moving them from latent TB to secondary tuberculosis? Have you perhaps ever seen such cases? Then my other question would be, so about the oral salbutamol, we now know in current practice that it's virtually almost useless, yet we still see so many cough syrups on the market, and we see them being promoted. Is it fair to say that perhaps as doctors, we should have a kind of a strong campaign to decampaign the use of those type of cough syrups with oral salbutamol? That should we actively go against it? Because there's a certain product that we all see being prescribed and it's used everywhere, yet it may not really have the desired effect. Then my other question is about the use of pulmonary function tests. Perhaps in the more kind of advanced countries, they may choose that before they give a definitive diagnosis of asthma. And are we always confident in giving that diagnosis here, where we may not be able to send everyone to Makerere Lung Institute, you know? And are we confident always in making the diagnosis of asthma without having done pulmonary function tests? And if and when they're done, I wanted to ask about the fact that in certain countries, they use race-based kind of calculations for people who are like African American or Black. And if at Lung Institute, you also you put that into consideration when you're looking at using the Global Lung Initiative's parametric calculations. Is that something that you've found yourself using? And then perhaps my last question is about Montelukast. So I've seen it being given a lot perhaps for use of allergic rhinitis, and even it has been mentioned extensively here, but you know that FDA has released a black box warning about its use, especially pertaining to the neuropsychiatric effects of Montelukast, from as far as suicide ideation, depression, to milder effects. In your experience, have you found that to be a relatively common adverse effect? And before starting your patients on them or on Montelukast, given the kind of the stigma against that type of mental illness, is that something you always disclose and divulge to your patients? Thank you once again.
Wow, lots of questions. Thank you, and thank you for that interest. So I'll try to go through all of them. Dr. Helen may add. So that bottle spacer, yes, not all our patients are able to afford the commercial available spacers, and we encourage them to use the bottle spacers rather than spraying the medication in the mouth. So the bottle spacers are equally effective. Indeed, I think they were started in South Africa. You can even look up the literature. If used appropriately, the bottle spacers are good, and they can lead to symptom control. The idea is that whether somebody is using the bottle spacer or the commercial available spacer, that technique is extremely important. The difference is that with the bottle spacers, you want to have a bottle with less folds, or what you would call corrugations, so that there is less room where the medication can stick and therefore not available for inhalation. But also we encourage them to change the bottles frequently, because as they get old, a little of the medicine that sticks on the sides makes more medicine stick there and therefore not available for inhalation, which is not the same when you're using commercially available spacers. But yes, they are effective if used correctly. The issue of latent TB, I want to emphasize that when we are using the anti-inflammatory ICS, it's working on the concept where we say there is dysregulation. In other words, you have a lot of the cytokines compared to what we all have cytokines, but these are out of hand. So when you're giving the anti-inflammatory, you're regulating the amounts that are expected. In other words, you're causing a balance between the pro and the anti-inflammatory. And I want to imagine that once you're not necessarily reducing to zero, but you're balancing, probably the issue of latent TB may not arise. But I think it's a subject for research. But I also want to emphasize, usually when we are trying to assess our patients, we try to look out for all these symptoms of TB. But yes, it's something which we would need to research and find out if it's possible. Oral salbutamol syrups, like I mentioned earlier, it's really a disservice that we are still using oral salbutamol. It has many more side effects. It's not as effective as the inhaled medication. Let's try as much as possible. And so I would call, the advocacy against this starts with us. Because if you prescribe a syrup containing salbutamol, when you have an opportunity to prescribe an inhaled SABA, then you're indirectly promoting the use of oral, salbutamol instead of giving the inhaled one. So I'm hoping that after this presentation, we'll try to check our practice and whenever possible, try to use the inhaled medication. Pulmonary function tests and how to confirm a diagnosis. So the common pulmonary function test that we use both in adults and children to try and confirm asthma is spirometry. I want to emphasize that a negative test or a normal spirometry test does not mean that the child cannot have asthma. Remember, I mentioned that this is a recurrence on and off airway obstruction. So if you do the test and it's at that point that the obstruction is not there, then you'll have normal lung volumes and flows, because that's what we test for in spirometry. So it doesn't mean that the child cannot have asthma. And therefore, it's extremely important that you do a comprehensive history. And that's what we use in most of the settings here to make a diagnosis of asthma. But also remember that in children who are less than 6 years, they cannot perform spirometry. And so you depend a lot on the history, which is usually typical. When you add that to the response to the treatment after giving, then you usually have a diagnosis of asthma. We also use them for monitoring. Yes, when we are performing spirometry, we consider ethnicity. All the softwares that we have are currently on the market. You must input the ethnicity so that the predicted values and the lower limits of normal and the Z scores of the patients that they get are weighed against the reference for that particular population. So yes, we use them. Montelukast, I'll ask Dr. Helen to comment about Montelukast, but yes, there is a black box that has come through, but let me invite Dr. Helen to make a comment about the use of Montelukast in our children. Thank you.
Okay, thank you very much. I tried to add some information on the chat. Now about Montelukast, yes, I have seen that in the past. Some the side effects were reported. At the beginning, they said they were being observed in like army men, and they were mental neurological side effects. A lot of discussion took place in there is an association called PEDLAM, like pediatric pulmonologists, and people gave their experiences and all that. And of course, the observation is that for younger children, the main issues are neurological, which may not affect the younger children. You know, those things of saying tendency to to wanting like to commit suicide and what that cannot, we don't really look for that in young children, but they may become hyperactive and all these things which can be observed. So like with all drugs, you have to watch for the side effects. But in our practice, I haven't really observed. I have had an instance, one where I had to stop the medication, but yes, and maybe our population is not the same as the other population. So for now, it's not a big problem. We are aware, and just like when we give any drug, we have to watch for untoward effects. I hope that answers the question. Yeah.
Yeah, thank you, Dr. Helen. I think Dr. Lillian, you'll allow us to wind up in the interest of time. But
Okay,
just before I wind up, there are two comments. Somebody asked about the levocetirizine montelukast combination. That combination is used in management of chronic allergic rhinitis, not asthma. I think that according to the way I understand the question, that it can be used to manage asthma. We usually give it for patients who have chronic allergic rhinitis to help control those symptoms. And then the other comment was about whether we're having advocacy efforts to have space as part of the things that can be procured from the national medical stores. How I wish that everyone here would join hands to advocate, because we can't do it alone. And that's the reason why we are coming to you. You see more patients than we do. So combined voices will help us to improve the availability of the inhalers. We have challenges with the doses. We hardly have inhalers that have 100 micrograms, 200 micrograms, 50 micrograms, and those are the doses we use in our children. Most of them are adult doses. We have few inhalers that are plain, like I mentioned, children who are less than 5 years. The preference is used to have plain inhaled corticosteroids. So I invite you to be part of really these efforts to see that our children get the best that can be availed to them. As I conclude, I have two, I think, messages or appeals to the team. Number one, to the extent possible, please consult colleagues. We consult a lot other colleagues because it can help a lot to avoid some of the errors that I mentioned earlier. And one of the things which consume a lot of time and effort is undo a statement that has been said by one of us. When a patient comes and says, "Doctor told me that my child cannot have asthma because they're not wheezing," you'll take another 2 hours explaining, but also several visits before you actually get a breakthrough. So let's consult each other. Let's read the guidelines available. Let's do the best that we can for our children. And then the other thing is that let's not just prescribe the medications. In our experience here at the Lung Institute, prescribing a medicine is not sufficient to cause asthma control. It starts with really the comprehensive history, the medication, a lot of communication so that you and the parent are on the same page. Please, whenever you prescribe inhaled medication, ensure that you demonstrate the inhaler technique. Otherwise, you'll not get a breakthrough, and then the patients will start saying that the inhalers don't work, and the message will spread that they do not eventually benefit. So my appeal is to try and mitigate the errors that I've mentioned. Let's communicate effectively, let's consult, let's read to see that we can really get the best out of what we have. I'll stop here, and I just want to thank everyone for really turning up for this presentation. And I'm happy my email is usually available, our telephone contacts are available. If you have any questions or concerns, you can always call, you can always email so that these conversations can continue. Thank you so much. And also to thank Dr. Nampijja for the case presentation. I hope you saw some of the errors in the presentation, which I've talked about, and also Dr. Lillian for really chairing this session, as well as Dr. Helen for providing her expert opinion. She's our senior consultant pediatric pulmonologist. So thank you so much, everyone.
Thank you very much.
Thank you so much, Dr. Rebecca Nantanda, for the nice presentation. I'm sure this is going to improve on the way we care for children who have asthma. So this brings us to the end of our webinar. Thank you so much for attending.